I'll focus on HFOV and where to next. So this is a very kind, simple gesture my colleagues put forth when the paper got published. I was on call, and this is what I was faced with on the unit, but there we are. And again, it's going back to the past masters, and again, it's back to the basics. We should make a habit of two things: help or at least do no harm. And I think therein lies the whole of mechanical ventilation. I'll just take you through this tragic case. This is a case report that's published in the New England a couple of years ago, almost a decade ago. And this is about a young girl who had an amniotic fluid emboli and developed severe respiratory distress. And those were the ventilating targets, where she was ventilated, and those were the targets to be achieved. And this is what happened to her lungs. So this is huge pneumatocysts and completely destroyed lungs on post-mortem. And this sort of really thrust in our face the whole concept of ventilator-induced lung injury. And there are about three major components: volutrauma, atelectrauma, and biotrauma. And Arthur Slutsky very eloquently summarized that if you ventilate patients badly, you have both biochemical, biophysical injuries leading to distal organ failure, multi-organ failure, and then increasing the risk of death. And this is a very simplistic schematic structure of the lung hysteresis, and this is where you want to be. You want to avoid de-recruitment, you want to avoid over-distension, and you want to go up this pressure volume curve and ventilate somewhere up there. And that's the basic, very fundamental principle of how lung protective strategy would work. And high-frequency oscillatory ventilation sort of seduces us into believing that this is the ideal way of doing it, in that it helps to keep the lung open. You're up here, and you're using less than equal to dead space tidal volume. So you're satisfying both these. You're preventing de-recruitment, you're preventing over-distension, and you're keeping the lung open both during inspiration and expiration, having better VQ match, better gas exchange, etc., and with less lung inflammation. Let's look at the evidence for that particular hypothesis. We look at some of the animal experiments, some of the human studies, and some of the large randomized control studies with high-frequency ventilation over the last 18-20 years. So this is the early HFOV papers where you said, relative preservation of the lung architecture as compared to significant destruction and edema whilst these animals were on conventional ventilation. And this is from Imai and Arthur Slutsky's group again. If you were to oscillate them, you have less release of cytokines as compared to doing conventional ventilation. So theoretically, it all sort of, in the animal world, it was perfect. And this was part of my MD, where we looked at lavage and serum cytokines in patients with high-frequency oscillation versus conventional ventilation. And you see there's a significant drop in serum IL-6 and a relative drop in BAL or BAL IL-6 at different time points, again suggesting that this could be a more lung protective strategy in terms of cytokines at least. Then Stephen Durdak's paper, published in the Blue Journal in 2002, was the first large randomized control study looking at oscillation versus conventional ventilation. And we'd probably recognize, as about that time, the right kind of sickness scores, about representative of what we would see. As you'd expect, the mean airway pressures are higher on conventional ventilation. On HFOV, you have better gas exchange on HFOV. And it fell short of that magical 0.05. So high-frequency ventilation, there's a trend towards better clinical outcome, but it did not achieve significance. What I'd like to point out in the study, though, was how did we ventilate the conventional arm here? Peak airway pressures of 35, 37, 38, 37. PEEP of, we'd accept that kind of PEEP. Tidal volumes about 8 to 10 mils per kg. And we were comparing that with high-frequency ventilation. And I hope and I believe we don't ventilate our patients like this anymore. And then we had, that was the American and Canadian oscillator trial. Then we had the European limb of the oscillator trial, which we had to close earlier because of lack of recruitment. But again, this trial was done in 6 centers across Europe, in centers that have been doing oscillation for quite some time. And again, we did there was no significant difference in survival. The conventional ventilator groups did slightly better, but there's no statistical significance. But when we analyzed it further, the patients who had severe oxygenation failure as compared to conventional did better on HFOV. So the sicker the patients, better the HFOV was. But that was the signal that was coming through. Then such ensued from the Canadian trials group, the meta-analysis published in the BMJ, which says, again, there was some signals that HFOV was better as compared to conventional ventilation in terms of outcomes at 30 days for patients with ALI and ARDS. And then around that time, we had the funding for the OSCAR trial, and I'm greatly indebted to all the nursing staff and the clinicians and the patients that participated. Just to give a feel for it, we had 25 units, and to train, of the 25 units, only 2 units had an oscillation before. So we had 23 HFOV naive units, and we spent about 5,000 hours worth of training to get people up to speed with doing high frequency ventilation. A huge amount of effort behind it. And I think something really important before we started off was we were held to this question by the HTA. It wasn't a scientific question we were asked to answer. The question that we were asked to answer, what would happen if HFOV was introduced across the ICUs in the UK? And would there hence be, with the introduction of HFOV for patients with ARDS, would we see a 30-day survival benefit? And hence the study was designed and conducted in the way it was. Standard inclusion exclusion criteria, we made sure that we did not sort of got the first patient got intubated, we kept them on 5 of PEEP, left them on it for some time, and in a pretty standard exclusion criteria. We used a new ventilator called the Metran or the Nova Lung. It has the advantage that you can do both conventional and high frequency ventilation on the same machine. Slightly more expensive, it's sexier, it's a lot quieter, and the nurses love it. Yeah? The other advantages beyond it being sexy is that the rotatory valve behind it is an electromagnetic valve. So, so what moves the diaphragm in the new machine is far more powerful, and hence you can get larger frequencies as compared to the Sensormedics, which is an old woofer system, not as powerful as the electromagnetic. So hence you don't get as much high frequencies in 100 or 120 kg person. But it's been extensively used in Japan. It was marketed through the company in Germany, and we chose to use it. We had what I would think a simple algorithm, and we can go through that later on. And all of the treatments were the same. The conventional arm, we recruited centers that said that they did ARDS net ventilation, that they would abide by a protocol in keeping with the ARDS net ventilation. We did not have funding to give a research nurse to each unit to make sure that they were compliant with the protocol every time. The funding was predominantly to lend the oscillator to the units and to provide the training. And there was some amount of network money that went with it. The 2 protocols, that's for oxygenation, and there's one for CO2 clearance. We stressed on the oxygenation during all our training that once the oxygenation improves, don't drop the mean airway pressure, drop the FiO2 first. Sit on your hands for some time, let the lungs recruit, and then start coming down on the mean airway pressure in keeping with the algorithm. The second thing to note is that the mean airway pressure was measured only once in the day at 8 o'clock in the morning. So even if the patient reached a mean air pressure 35 at midnight and then came down slowly to 21, 22, it was measured at 21, 22. The highest mean air pressure wasn't recorded in the charts. We only recorded once a day at 8 a.m. And that's how the CRF and the trial was designed. And that has implications on how we interpret the data later on. And this is a Consort diagram. Again, it's quite important. And about a quarter of all the patients who were screened were recruited and randomized into the study. And I say that's important because when we look at the Proning paper, when you look at applications, how you can apply science to day-to-day practice, in the Proning paper, the Gurin paper, only 5% of patients who were screened got recruited into this trial. So where is the applicability of the protocols into clinical practice? That's a recruitment graph. These are the two pandemic seasons, and you can see as following the pandemic, we had a huge surge in recruitment. And that's the Apache score between conventional and high frequency. Pretty sick patients, almost similar to the Current. They're the cutoff of 150. We have 120 as your mean. And tidal volumes, now this is what I want to discuss later on, that baseline tidal volumes about 8 mils per kg. And these are all the units who swore by following ARDS net protocol. And I was one of them. The mean airway pressure in the high frequency group is 26. In high frequency is 26, 25, 35. And this is probably underrepresentation of what the actual mean air pressure we reached, because it's only collected once a day. We did not collect the highest and lowest for those 24 hours. Because if you're writing a CRF, to write in when do you start your 24 hours, from the time you recruit the patient, from midnight to midnight, when the shifts change. So we decided just once a day. And maybe that's the reason why it really looks as bad as it is. Again, we were able to use high frequency. The tidal volumes in the conventional group was high. And as you all know, the same number of patients survived in both groups as they died in both groups. Essentially, there was no difference. There's no benefit in patient being on high frequency ventilation at 30 days. And this is the Kaplan-Meier graph. Again, no difference. Then we have the Canadian trial. That's the Oscillator trial. And they started off from a slightly different premise, that they had a scientific question for which they got funding for. And their scientific question was, what is the effect of early HF4 versus best current clinical practice? Two big differences there in that they used centers that were already using oscillators, so they did not have to spend money on buying or lending or leasing new oscillators. And they were able to have one research nurse dedicated to monitoring compliance with 6 mils per kg. And again, we can go, these are the inclusion, exclusion criteria. Big difference here, they use 10 centimeters of PEEP to differentiate. Exclusion criteria are pretty much the same. And again, that's a Consort diagram. Again, about 25% of all patients screened were recruited into the trial. And that's the baseline. And this is the big difference in, and Tim alluded to earlier, in how they applied PEEP in the study. We don't do 18 of PEEP at 50% FiO2. I can't even think at 80% FiO2, most of us would do 20 of PEEP. Anyone who has reached 20 of PEEP in the last 6 months? Yeah, so. Luigi. The Apache score was 29. Any reason why their patients were sicker when the ARDS criteria were the same? Their Apache score was recorded on the day they got recruited into the trial, not on the day they got admitted onto the unit. So hence not comparable. And there's a New England Journal letter following the publication that this is not a day of entry to ITU Apache score. This is day of entry into the trial Apache score. Again, impressive tidal volumes at baseline. We were doing 8.3, they're doing 7.2 even before the trial started. And tidal volumes right throughout, 6, 6.6, and only later on going up to 7 mils per kg. So their compliance with 6 mils per kg was absolutely perfect. They also had a higher amount of PEEP used. 18, up here, 13, 11. How many of us will use 11 centimeters PEEP on day 7? Not many. And again, a big difference in the fluid balance. The oscillated group had a lot more fluid on board, and we know aggressive fluid resuscitation and being positive fluid balance has an impact on ITU length of stay. Definitely not on mortality, but at least on the length of stay. In the oscillate group, the HFOV group had a greater amount of vasopressor usage, greater amount of neuromuscular usage, and the outcome was that they had to stop the study at the interim analysis because there's an increased signal towards harm in the high frequency group. So the study was stopped early. Again, all the caveats and advantage and disadvantage of stopping a study early. And that difference on the Kaplan-Meier at 60 days continued. The control did much better than the high frequency. So let's just look at a bit of an old-fashioned compare and contrast, because it's quite important that we understand what we both try to achieve and where we are with high-frequency ventilation. I really don't believe that the kind of machine that you used was really different. The distribution of gases is, okay, these are all minor issues. The big issues are up here, that they use centers that had HFOV experience. We use HFOV naive centers. But they had a different question to answer. We were asked to answer a different question. They did recruitment maneuvers in their protocol, and 19 out of the 275 patients developed barotrauma. In the OSCAR, 13 out of 378 patients developed barotrauma. So maybe doing recruitment maneuvers was associated with increased risk of barotrauma. And the protocol that they use for barotrauma is published in a trial called the TOOLS trial, which is quite an aggressive recruitment that you take on the oscillator 40 centimeters of water for 40 seconds every 6 to 8 hours. We've discussed the mean air pressure. And again, the mean air pressure probably higher in this study because they recorded the maximum mean air pressure. We recorded the mean air pressure on the day, just once a day at 8 o'clock in the morning. And we discussed the Apache 2 score as well, that this is on the day of recruitment into the trial. This is at admission. But this is the biggest worry for me. 6 ml per kg, 8.3 mL per kg. So OSCAR was an effectiveness study. What would happen if you brought it out with best clinical practice? What would it affect? How would it affect mortality? And in what we've shown through the trial, it doesn't really affect mortality if we just brought it out into routine clinical practice. But the big worry was, it's almost like an audit, a very expensive audit on UK tidal volume practices. 8.3 mL per kg. And I can ask the question in the room, do we all practice ARDS net? And all of us, I swear, will say yes. That's a big problem in what we think we do and actually what we deliver. Oscillate was an efficacy study. They asked a scientific question which they tried to answer. And again, 6.1 mL per kg tidal volume. So have we missed a trick along the way in trying to do the study? That the emphasis, I think, with high frequency should be in low tidal volumes and prevention of harm with volutrauma. And all our recruitment, all the protocols were designed to aid recruitment. And here is the philosophical problem in that we use improvement in oxygenation as a marker for improvement in lung inflammation in ARDS. And that's why all the emphasis on recruitment maneuvers, pressure volume curves, going up on this, going up on that. But there's no trial that has so far shown that improvement in oxygenation is equal to reduction in lung inflammation, which is equal to better outcomes. So we focus so far so much on recruitment that we've forgotten the real trick lies in prevention of volutrauma. And the other big difference is the obsessive, meticulous attention to 6 mL per kg. And I'm just using 6 mL per kg as an example here. But they delivered what they set out. And the real big signal that comes out is 8 mL per kg and 6 mL per kg. And in teasing it out even further is that they had a research nurse to help deliver 6 mL per kg. We don't have the resource for somebody to stand at the bedside to deliver 6 mL per kg 24/7. Yeah, and that's what somebody asked the question, how do you translate clinical science, research, randomized control studies into clinical? There is a big problem because when you're doing a randomized control study, you are given resource and a very specific small group of patients to do your trial on. And I think a lot more attention, as we'll discuss in the next few slides, is how do we translate that on a day-to-day basis? So what now? Anyone recognize this gentleman? Yeah, fantastic. Who is that? Okay, brilliant. And why is he so important to intensive care? Ah, brilliant. And that's what I want to focus on. You know, to improve outcomes from ARDS, you don't need better ventilators. You need a team of people who have a singular aim of making outcomes better. We know what we want to achieve. We need to measure where we are before we can say where we want to get to. And we need a cunning plan. And what's the definition of madness? Doing the same thing again and again, expecting different results. Yeah, so we've done the same story for the last 20 years. We really need to think outside the box to see how we can make that difference. And that's simply put, small improvements in a number of different aspects can have a huge impact on overall performance of the team. You need a good team. You need medics. I think medical staff are sometimes more harmful to the patient than beneficial. This is kind of a very lateral question. One of the reasons why I think proning actually helps patients is because doctors don't go and mess around with the ventilators once the patient is prone. You very rarely go and tweak the PEEP or do a pressure volume analysis when a patient is when he's prone. When they're supine, you go and just mess around with everything. You know better than your next consultant colleague. When they're prone, everybody's the same. So we do harm. We need good nursing staff. There's no point me talking to medics all the time and the nurse at the bedside doesn't know what to do with respiratory acidosis when you're gone for 6 mils per kg. We need good physiotherapists, dietitians, IT technicians. And I'll come to why we need IT technicians and data managers. We need to understand what we want to achieve. Compliance with low tidal volume, bundle care, if you believe in bundle cares and bundles. We need appropriate antibiotics. We need appropriate antibiotics to be prescribed and delivered at the time we want it. There's a fantastic New England Journal paper looking at Gleevec for the treatment of CML, and they're talking about resistance to Gleevec. Gleevec is the Philadelphia chromosome reverser. And we know what was the biggest reason for resistance to Gleevec? The patients weren't taking it regularly. That's why the CML had relapsed. So compliance with treatment is so important. Data managers. So we work with Draeger and the Innovian team, and we've got 4 data managers looking at data and audit snapshots. And when we go to the regional meetings, we present our 6 mils per kg tidal volume. Our compliance about a year ago was 6 mils per kg. When we're measuring continuously for 24 hours through an IT system, it's about 25%. My colleagues, and I see somebody else's data, they have 45-50% compliance. They're measuring it once in a week. I'm measuring it 24 hours a day. You need a cunning plan. I've got a really cunning, benevolent colleague of mine. He's called Chris Bordeaux. And what he has evolved over a period of time, that through education and training, we really haven't achieved much. We used to bang on every induction, chlorhexidine should be prescribed. You know what we said? Hell with the whole system of training and education. We made it mandatory that every time you open the IT system and you're prescribing, chlorhexidine is automatically prescribed. And the compliance goes up from 60% to almost 100%. Voluven, yeah? We started saying starch is bad, shouldn't use this, shouldn't use that, spend years in teaching them. Now we said on the system, if you want to prescribe it, it's on the furthest corner of the IT system. So if you really want to prescribe it, look on the IT system and prescribe it. All my colleagues who believe, no, starch is good, we should prescribe it, did not want to scroll through 2 more pages on the IT system to prescribe Voluven. And here's the compliance. The prescription Voluven almost disappears. So you need a cunning plan. Yeah? So this is what he has done now. On the unit, we have 2 large plasma screens on either sides of the unit, and with the aim to reduce tidal volumes, to reduce hyperoxia, and reducing pressure source. And we have a continuous expression of data against the bed numbers of what is the tidal volume. So this is spontaneous, it doesn't come up. On a ventilated patient, this is amber, which is more than 6, and it's more than 8, it's red. And we're measuring the response time. Once the tidal volumes are amber and red, what is the response time for anyone in the unit to go and change the tidal volume? So that resulted in 10%, 15% improvement. And I said, he's cunning. But what he does, we work a week at a time. So at the end of the week, he emails everyone the compliance with tidal volume for the consultant working for that week. Yeah? How many of you go cycling? Yeah, and when you're cycling, you have those apps which says, you're cycling faster than the guy next to you. Yeah, and just by that competitive nature, we've now improved our compliance from about 24, 25% to 35% to 45% and reaching 56%. And he has not done any training in education. He's just not even shaming and naming. He just sends it out every week. So you need a cunning plan. But we also need strategies to treat ARDS. Now, these are all 4 pictures with ARDS. This is strep pneumonia. This was our first patient with H1N1. This is a perforated sigmoid, and this was a young man with aplastic anemia with diffuse lung injury. 4 different conditions, exactly the same in terms of ARDS net definition, entirely different treatment. We need to prevent volutrauma. There's very little in medicine that is cheap and cheerful. There's very little that says that by reducing something, you get better outcomes. And I can't think of anything that gives you an absolute reduction of 8.8% in mortality. And even though we have such a powerful tool in our hands, I think our compliance with the protocol is poor. Neuromuscular blockade. I like this paper, not because it assists atrium or anything, it's because I laugh at my orthopedic colleagues. And I still laugh at them, but I also have learned something from them. And what I've learned from them is when you fracture your arm, what does he do? He doesn't do it, but the nurse and then the people in the A&E department do it. There's a bit of empathy. Immobilize it. And he doesn't open the plaster every day or every week to see how it is healing. He leaves it for 6 weeks. However intelligent he is or not, he doesn't challenge that norm. He leaves it for 6 weeks, and after 6 weeks, he flogs you. You go in for rehab, exercise the arm, exercise the leg. And what do we do with ARDS? We try to make the patients work harder from time 0. So I think this paper is great, not because, of course, it's great for the design and the way it is conducted and all the science behind the cystatricurium, but also it tries to remind us that the lung is injured. It needs to rest a bit. Whether the period of rest is 24 hours or 48 hours or 72 hours, I don't know. I think the period of rest is equal to the lung inflammation coming down. That is temperature, tachycardia, CRP, white cells, or any other better surrogates that we may have in time to come. But we need to rest the lungs before we start flogging them. And even when you look at the data, if you look further down, the length of stay on the ventilator was less, the length of stay on ITU was less, the less of neuromuscular paralysis was less in the group that was rested for longer. I would love to be rested a bit when I'm tired. Prone positioning, great paper. Yeah? But I want, again, fantastic outcomes. But also look at the conventional arm. They were meticulous with the 6 mils per kg. And also, we need to think carefully. Only about 5 to 6% of the patients screened with ARDS actually got recruited into the trial. So before we jump up and down and say, every patient of mine should get prone, we just need to apply a bit more translational research and say, does this really apply to my group of patients? Conservative fluid management, having a patient, you have to resuscitate the patient when they need to be resuscitated. Once the resuscitation phase is over, I think there's very little scope for laziness. We really need to run them dry. At least it reduces the length of stay on the ITU, if not improves mortality. And again, there's no harm in terms of increased renal failure if you were to run them dry. And again, if I was to spend 20 minutes talking about meticulous care in 30 degrees head-eye, good oral hygiene, how many of us examine our patient's mouth when we start the ward rounds? Redundant question, isn't it? But we know the data that oral commensals almost reflects what's happening with commensals in the lungs. It's the same organism that causes VAP. Yeah, but if I spend 20 minutes, I'll never get invited to do a talk again. Yeah? DVT prevention, stress ulcer prophylaxis, daily sedation breaks, prevention of hospital-acquired infections, central line, peripheral line bundles. Yeah? You really need a good governance structure to make sure why should a patient develop a peripheral line infection. Yeah, we are only so focused about the 6 mils per kg, but there's a whole patient around the 6 mils per kg. And I want to see whether this is, just let me see, okay. So this is the aggregated marginal gain hypothesis. And I want to just explore whether that truly does make a difference to outcome. Yeah, so this is a paper from Minnesota, and they looked at patients admitted to their hospital over 7 years. Yeah. In terms of demographics, the age remains the same. The Apache score is greater as the years have gone on, but the ITU mortality is less, and statistically less. The hospital mortality is statistically less as well. So what's going on? This is a population-based study. So what's going on in Minnesota? That over 7 years, the age is the same, the sickness has gone up, but the mortality has come down. They broke the ARDS into two groups, the community-acquired ARDS, and the mortality remains the same. But the hospital-acquired ARDS, the mortality has dropped dramatically. Any explanation for that? How would you prevent community-acquired ARDS? It's a cheap and cheerful way. It's so unglamorous. Vaccination. Uptake of vaccination is poor. That's why the ARDS from community-acquired infection remains roughly the same. But what they did in the hospital, transfusion practices have changed. Mechanical ventilation has changed. Resuscitation bundles have changed. Pneumonia scores, in the way we staff our unit, rapid response team, records. All these small changes have gone on resulting in a significant reduction in mortality from hospital-acquired ARDS. So I think that marginal gain, making small stepwise changes in everything that we do, has an impact. So what next? Do we change our targets? Do we use outcome as a quality marker? Should we all be publishing, like the cardiologists or the cardiothoracic surgeons publish the data on ARDS? Should we use information better? Regionalize our services? Is it time to change our language? But we talk about permissive hypercapnia, like it's an uncomfortable side effect. Or should we change it to therapeutic hypercapnia? Because we know from all the trials, right from Amato till now, that all the patients in the trial groups that have hypercapnic acidosis actually did better. And there's some very good animal work to show that actually hypercapnic acidosis actually is anti-inflammatory. We believe in normal oxygen levels, or should we go for permissive hypoxia? Again, all the discussion so far is improving oxygenation. And this is such a powerful slide from the ARDSnet, that in the group that had 6 mils per kg were more hypoxic for longer but survived better. So our obsession with getting oxygenation sorted out. So we should really change the way we teach ourselves. We should accept a bit of permissive hypoxia. Improving oxygenation in itself does not equate to improved outcomes. Aggregation marginal gains, we saw it works. We should benchmark ARDS mortality. It's not naming and shaming, it's exactly the competitive spirit. If I can get 60% survival, why is the other guy doing 50%? And I think we should regionalize services. For units to say they're going to use the oscillator or some other service for just once or twice a year and expect to get good outcomes from it, I think is wrong. We regionalize service for almost all other things. So for oncology, for hematology, for upper GI surgeries, vascular, it all gets regionalized. And I think we need to have better collaboration in terms of the scientific principles, conduct research in an orderly fashion, and be sincere about publishing our results. So to conclude, I think we should use low tidal volume as gold standard. There's debate, and we can debate later on about whether you should high PEEP or the ARDSnet PEEP. We should consider proning, neuromuscular blockage, regionalization of services, a strong governance structure to make sure the things that we are doing, we want to deliver, we actually deliver and measure it well. And from the Oscar, Oscillate, Emote, Mote studies the last 15, 20 years, there is no real evidence to say that HFOV has a role across the spectrum to prevent ventilator-induced lung injury or early ARDS. It possibly does have a role in rescue therapy. And of course, for those who use it very well, who are HFOV enthusiasts, if they can do it well, absolutely fine with it. So to conclude, I think mechanical ventilation still does the job. Thank you.